specialty. Now I will request our next presenter, Dr. Ferdous Akhter Jolly. She will be presenting her topic, and she is an associate professor of ophthalmology, Bardem General Hospital. Dr. Ferdous Akhter Jolly, please.
Good evening. I am very much thankful to Ophthalmological Society of Bangladesh and All India Ophthalmological Society for giving me the opportunity. Today, my topic is phacoemulsification in vitrectomized eyes, a nightmare or a daydream. Even the most courageous human in history may have one common thing, that is a dreaded nightmare and ophthalmologist's nightmare, or maybe a nightmare dressed as a daydream is post-vitrectomized eyes awaiting for phacoemulsification. We know cataract develops and progresses in up to 70% of patients within 2 years after persplanar vitrectomy. So cataract surgeons need to understand the higher risk of intraoperative complications in these cases, and also successful cataract surgery is necessary to restore vision and also to give clear view to the vitreoretinal specialist to monitor posterior segment. Why phaco is challenging in case of vitrectomized eyes? Number one, cataract that develops following vitrectomy are the denser nuclear sclerosis and also posterior subcapsular type rather than senile cataract. Number two, that patients have small pupils that prone to develop reverse pupillary block. Lack of posterior support for the cataractous lens makes performing capsulorhexis more difficult. Removal of lens matter also became complicated, and more anterior chamber depth fluctuation. Number four, occult zonular dehiscence may happen. Number five, posterior capsular damage or posterior capsular fibrosis may be developed that lead to increased chance of nucleus drop during surgery. Now, I want to share a few such cases that I have faced very much challenges. One case, 35 years diabetic, high myopic patient who had a history of trauma in right eye in 2004 and developed rhegmatogenous retinal detachment with subretinal hemorrhage and choroidal effusion in right eye, and underwent 360-degree bell buckle persplanar vitrectomy, endolaser, and C3F8 gas exchange in right eye in 2004. That patient came to us in 2019 September with gross deterioration of vision. His visual acuity was counting finger 2 feet in both eyes, dense cataract in both eyes, and as much as I could notice through slit lamp, there was no phacodonesis or zonular instability. Fundoscopy was not possible due to dense cataract, and B-scan shows attached to retina. So our plan was to do phacoemulsification with posterior chamber IOL implantation in right eye under local anesthesia. So we started phaco, but there was an unpleasant surprise waiting for me, that is zonular dehiscence extending from 4 to 8 o'clock areas. In this case, capsulorhexis became very much difficult as there was zonular dehiscence and lack of posterior support, and I have to put viscoelastic substance several times to complete the capsulorhexis. Then I introduced CTR into the bag, and I couldn't have a segment at that time. And one thing we should keep in mind, that opening of the CTR should be opposite to zonular dehiscence. And then I did hydrodissection and hydrodelineation very generously, and here nuclear rotation was not possible after trying several times. Then I tried to complete the phaco. Then I complete the phaco with low flow rate and low vacuum, and as there was to reduce the stress in the capsular bag. Lastly, I completed the phaco and introduced multipiece IOL into the bag, and placing the haptic of IOL along towards the zonular dehiscence area. If we could see any zonular dehiscence during surgery, we have two options in hand. One, we can continue phaco with capsular hook in the zonular dehiscence part, or we can do phaco with the help of CTR or segment, or we can convert the case into ICC with SF-IOL implantation. Now I will share two small people cases. One case, 62 years diabetic male, had advanced diabetic eye disease in right eye and underwent pars-plana vitrectomy, membrane peeling, endolaser, and fluid air exchange in right eye. That patient came to us with cataract and small pupils. We planned to do phaco with the help of hook. And another small pupil case, high myopic 45 years, that patient had rhegmatogenous retinal detachment and underwent pars-plana vitrectomy with fluid air exchange, endolaser, and silicone oil implant in right eye. That patient had cataract with small pupil along with silicone oil in the anterior chamber and posterior synechia in that eye. We plan to do phaco with B-hex ring. My first small pupil case, in that case I used iris hook to enlarge the pupil and then completed the phaco in usual where I did here direct chop method, and I preferred to use multipiece IOL in vitrectomized eyes. And another small pupil case, that patient had silicone oil in the anterior chamber, so I had to wash the anterior chamber and clean the silicone oil at first. Then I introduced B-hex, then I did synechiolysis for posterior synechia. After that, introduced B-hex ring to enlarge the pupil. Thereafter, rest of the portion of the phaco is uneventful, and I did here direct chop method to reduce the stress over the capsular bag. Now another case, posterior capsular fibrosis, that is 57 years old male, diabetic male, had vitreous hemorrhage in left eye for a long period and had history of pars-plana vitrectomy, membrane peeling, endolaser, and silicone oil implant in left eye. That patient referred by a VR surgeon. There might be a defect in the posterior capsule or damage during pars-plana vitrectomy. So that case, I completed that case as a posterior polar cataract. Here, we should not do hydrodissection. Only we did hydrodelineation, and there was no capsular damage, only capsular fibrosis in that case. And here also I implanted multipiece IOL into the bag. Another option is there for post-vitrectomized case, that is femtosecond laser-assisted cataract surgery, that paves a new way to complete cataract surgery and to do capsulorhexis and nuclear fragmentation with the help of femtosecond laser-assisted cataract surgery, and to also we can reduce the stress over the capsular bag, and also it is helpful for zonular dehiscence cases. Now I will share some pre and post-operative considerations. Number one, biometry. IOL power calculation may be inaccurate in that cases, as there is possibility of hypermetropic surprise. As the vitrectomized case, IOL lens may be more posteriorly placed, and optical biometry is more accurate than ultrasound biometry in vitrectomized eyes. In case of silicone IOL filled eyes, axial length measurement will be inaccurately long unless compensating factor is used. Many of the machines have provisions for calculating axial length in silicone oil filled eye. And if cataract is dense, in that case, immersion ultrasound is preferable. Informed consent process for the vitrectomized eyes should be customized to take into account the several unique challenges that may happen during cataract surgery. And increased patients and patients' attendants should be informed about the increased risk of perioperative events. IOL selection also important. Here, cheapest IOL may be necessary for implanting into the bag or into the ciliary sulcus. And in postoperative case care, we should give oral acetazolamide, as there is always not possible to complete removal of viscoelastic substance because of zonular dehiscence, and to reduce the intraocular immediate postoperative intraocular pressure, and also to give oral acetazolamide to reduce immediate postoperative inflammation. And in long-term care, the cases of vitrectomized cases have developed higher risk of development of posterior capsular opacity with a rate of 8 to 51% cases in sequential surgery. And patients who have had vitrectomy for repair of retinal detachment may develop redetachment following cataract surgery with a rate of 5.6% cases. So, in surgical tips, we have to kept in mind that is CTR, iris retractor or pupil dilating devices should be kept in hand even if the pupil is dilated during preoperatively. To use reduced infusion pressure and lower the bottle height. And in posterior capsular plaque, posterior capsule prone to rupture, better to avoid hydrodissection and manage the case like a posterior polar cataract. And use of intravitreal liquid perfusion to ensure intraoperative IOP control. Corneal wound more likely, so we could suture the main wound to prevent postoperative endophthalmitis. And also use of topical steroid for at least 6 weeks after surgery, as this case is more prone to inflammation for prolonged period. Thank you all for patience hearing.
Thank you, Dr. Ferdous Akhter Jolly. And as a VR surgeon, we have to give the pain, that is the pain to our cataract colics every time the vitrectomized eyes, they are taking this pain. Now I will request our next presenter, Dr. Prakash Chaudhary. He will be presenting on his topic is our cataract. And after this session, if time permits, we will take some questions. So now I request